Good evening. The lecture for today is regarding the plaque biofilm control. And we'll be talking about both mechanical and chemical plaque control. Now, the most important thing about the plaque control, which we also refer to as periodontal self-care, it's an effective way of treating and preventing gingivitis. And it is also an essential part which is involved in the treatment of periodontal diseases. Now, what makes it so important is it started a way long back, almost, in 1965, when Lowe and colleagues, they conducted a classical study, to regard the relationship between plaque biofilm control and the development of experimental gingivitis. And by this experiment, it was noticed that, the patients who had stopped brushing and other oral hygiene aids resulted in the development of gingivitis within 7 to 21 days. So that led to the conclusion that a good supragingival biofilm control can effectively reduce the growth and composition of subgingival flora, and also it favors a healthier flora and reduces calculus formation and the maintenance of the oral health. So the regular removal of the plaque biofilm and the prevention is of utmost importance in preventing the accumulation of supragingival plaque formation. Now, how to maintain, or who is responsible for maintaining? Now, the plaque removal, the dental plaque removal, it's a responsibility definitely of the patient, because without assuming a responsibility of cleaning one's own oral hygiene, we cannot educate the patient or reinforce the habit onto that patient. And then comes the professional health by the dentist itself and also the hygienist. Now, the microbial plaque growth, it can occur every 48 hours, even in a clean mouth. That is, even after toothbrushing, it can start plaque accumulating within hours. And it can lead to deposition of the plaque and calculus, resulting in gingivitis. Now, according to the ADA specification, American Dental Association recommends that individuals should brush twice a day and also use other interdental aids to clean once per day to effectively remove the microbial plaque and to prevent gingivitis. Now, why this has to happen that twice a day? Because most of the time we have seen that the individuals do not adequately remove microbial biofilm at one brushing, and doing it again a second time will definitely improve the result. And the average daily plaque control, daily brushing, it lasts less than a minute, and it removes only like a 40% of biofilm. Now, the periodontal lesions are predominantly found in the cervical area and also in the interdental area. And usually, the mass of biofilm first develop along the molar premolar area. They usually corresponding to the opening of the parotid duct, and which is followed by the facial surface of the molar and the premolar and the proximal surface of anterior teeth. The lingual surface accumulate the least amount of biofilm, mainly due to the cleansing action of the tongue. And usually the patient has more plaque biofilm on the posterior teeth than the anterior teeth. And then comes the interproximal area with the highest amount of the biofilm. Now, when you talk about the plaque biofilm control, we have mainly two ways, mainly by mechanical and by chemical. Now, the mechanical is the most dependable way to achieve oral health for all dental patients. And the chemical, whereas on the other hand, they are adjunctive agents to mechanical plaque control. Now, the daily plaque control or the practice, it results in an improvement in the gingival health. And when you stop the plaque control, many of the studies, the evidence-based, when you talk about evidence-based studies, we have seen that there is accumulation of thick plaque on the tooth surface with inflammation of the gingiva, and also there will be a change in the flora, which these can be reversible back to normal if you assume the plaque control practices. So going back to the mechanical one, mechanical plaque control is mainly depending on cleaning with a toothbrush and other oral hygiene aids. Now, when we talk about toothbrushes, it's like the most widely used for cleaning the teeth. They can vary in size, in design, and also in length, the hardness of the toothbrush, and also the arrangement of the bristle. And you can see tons of advertisements regarding the toothbrush in the design, and also the minor modifications in the placement of the bristles, the stiffness of the bristle, the length. And all this claim to have superior qualities than the other toothbrushes. And this is all dependent upon short-term clinical studies. However, all these studies, they are mainly conducted based on the differences in the gingival score or the bleeding score, and which are, by the way, the primary indicators for the gingival health. And most of the studies have shown not much change between different type of toothbrushes. And even in one study, they conducted a study with 4 toothbrush using the same technique, but all these have shown that the removal of the plaque biofilm, it's almost the same with with these toothbrushes. When you talk about the part of a toothbrush, mainly it has got the head, which has the bristles, and then we have the handle. Now, early toothbrushes were mainly made up of hawk. We call that natural. And then they were usually like very hard and stiff. Hard bristle toothbrushes have been shown to abrade the tooth surface and also to cause irritation to the gingiva. But still we have few remaining, but nowadays we mainly go for the nylon toothbrushes. So when you recommend a particular toothbrush, always keep in mind that ease of use by the patient is of utmost importance. And the effectiveness of potential injury from different types of brushes depend to a greater degree on how the brush is used. So that we have to keep in mind when you talk about the design. Now the manual toothbrush, we get different head design or shape. We have the conventional one, then we have the diamond shape, then we the super brush, and then the size. But always when you recommend it to the patient, it depends upon the manual dexterity and the ease of use by the patient. Now coming to the toothbrush bristles, the bristles are mainly grouped into tuft, and each tuft usually has 3 or 4 rows. We have the rounded bristle end, which cause less scratches than with the sharp ends. And mainly we have 2 types of bristle materials. Either it can be nylon or it can be like bristles from hog. And nowadays nylon filaments, they are the one predominating in the market. But the bristle hardness proportional, or we call it as it's proportional to the square diameter of the bristle, whereas it is inversely proportional to the length. That means if the length is longer, the hardness will be less. But whereas if the diameter is bigger, the hardness will be the same. So depending on that, we can classify the toothbrushes accordingly. That is the soft one, which is like 0.2 millimeters in diameter, whereas medium it is 0.3 and hard is 0.4. That means if the diameter increases, the hardness also increases. Now, the soft brushes, they have gained more acceptance than the hard ones. The bristles, when they are very soft, they are more flexible and they clean below the gingival margin. And mainly when we use the technique, the circular technique. And it can reach even further beyond the proximal surfaces. Whereas the hard bristled one, it can cause more abrasion to the gingiva, which we call it as gingival recession. However, the manner in which the bristle or the brush is used, it has a factor, it is an important factor, but an equally important thing is the nature of the dentifrice which is used for brushing. Now, the amount of the force used to brush, it is not critical for biofilm removal. That means we don't have to go for a vigorous toothbrushing to remove the plaque biofilm. And this can lead to gingival recession, or it can later even lead to the wedge-shaped defect along the cervical portion of the tooth. Now, when you talk about the difference between manual and the nylon toothbrush, the plaque removal, it's almost the same. Predominating in the market, it is mainly the nylon. The bristle size, the elasticity, and the resistance is almost the same. But the fraying, the contamination, and the softening is more happening in the natural one than in the nylon one. How to replace or when to replace the toothbrush? Toothbrush must be replaced periodically, but although the amount of the visible bristle wear does not appear to affect the plaque biofilm removal up to like 9 weeks. So with regular use, the brushes show wear. So usually, the dentist usually recommended to replace the toothbrush every 3 months. And this is like a scanning electron microscopic image of, this is the clean toothbrush, and which is like the higher magnification. And the lower one, we can see the used one. You can see the amount of fraying happening. And this is like the bacteria which is deposited on the bristle surface. The handle brush. The handle of the toothbrush, it is available in different forms. We have the straight, we have the contra angle, flexible, even the slip handle prevention. All this can be used. It all depends upon the patient's ease to have grip, and also it depends on their ease of using the toothbrush. And coming to the selection, when recommending toothbrush, keep this general recommendation. Mainly we go for soft nylon toothbrushes, and which can be replaced, which should be replaced every 3 months. The toothbrush which is becoming worn due to wear and should be replaced accordingly. And the other factors should be considered is mainly the patient interest, the morphology of the dentition, and the manual dexterity. When we talk about the manual dexterity, we have to talk about the powered toothbrushes. So the acceptable manual toothbrush is, according to the ADA, we have the length, it is like dependent on like 25 to 31 millimeter, with a width of 7 to 9.5 millimeter, 2 to 4 rows, and tuft 5 to 12. And usually they prefer the straight hand pieces. Straight handle, we have the nylon bristles with 3 rows of tuft. And most commonly recommended is the short head, so that it is like accessible even to the posterior areas of the mouth. Straight cut round-ended bristles with 3 to 4 rows of tuft. Why the powered toothbrush came into it? Electrically powered toothbrush, it was designed long back, mainly in the 30s itself. And nowadays, even we have additional features of like oscillatory motions, circular motions, and some even we have the combination, and recently even we have the low frequency acoustic energy powered toothbrushes to enhance cleaning. Now, powered toothbrushes mainly rely on mechanical contact between the bristles and the gingival on margin and the tooth to remove the plaque biofilm. And this vibration helps in removing the bacteria which is adhere on the tooth surface. Now, there are different types of powered toothbrushes available. Typically, when we do any new methods for removing plaque removal, we do a study between the manual one and the powered toothbrush. But most of the study have shown that very little difference in the plaque removal between the manual and the powered. Even a systematic review reported that the mechanical brushes with oscillating and the rotating motion demonstrated 11% better plaque removal and also a greater reduction, almost 6% reduction in gingival bleeding than manual bleeding. But all these studies were related to short-term studies, and long-term benefits have not been established. So this particular style, we cannot consider it to be of greater advantage over the manual thing. Only thing is that the powered toothbrushes has been shown to improve oral health for the children, for adolescent, or patients lacking manual dexterity. Even in hospitalized patients, when we have the caretakers, or in patients with fixed appliances. Now, coming to the dentifrice. What is the importance of dentifrice in plaque removal? Dentifrice helps in cleaning and polishing, and they are mainly available in the form of paste or as gel or as powder. Mainly it contains abrasive, 20 to 40% abrasive, mainly aluminum oxide, silicon oxide, and polyvinyl chloride. And it has water, humectants, flavoring and sweetening agent. And sometimes it even contains therapeutic agents such as fluorides and pyrophosphonates. Fluorides, when we talk about it, mainly it is at the concentration in the level of 1000 to 1100 parts per million. Pyrophosphate, on the other hand, they are like anti-calculus formative agents, and it can also be incorporated into toothpaste. Now, these abrasives are of important factors in the toothpaste. Mainly, the abrasives are insoluble inorganic salt, and they really abrade the tooth surface. And the abrasion on the enamel, it's like, as you know, it's the hardest tissue in the human body. It does not abrade fast. Whereas for dentin, it abrades 25 times faster than the enamel. And when it comes to cementum, it is almost like 35 times than the dentin. So when you expose it, when the root surfaces is exposed with these abrasives, it can result in notching and tooth sensitivity. So the oral hygiene procedures that use abrasive toothpaste are the main cause of hard tissue damage than the procedure itself, than the technique itself. And also we can help it in using therapeutic agents such as fluoride and pyrophosphate. Now, pyrophosphates have shown to reduce the formation of new calculus. And that means that, you know, before we use this pyrophosphate, there should be the inhibitory effect of this deposition of new supragingival calculus is not affecting the existing one. So to achieve the greatest effect from this toothpaste, the teeth should be cleaned and completely free of supragingival calculus before adding this toothpaste to the regimen. So only it helps preventing new calculus formation. The techniques, the brushing techniques, it is always a personal choice. It solely depends on the person's dexterity, motivation, and individual needs. There is no clear superiority of any techniques. Mainly, the techniques we use are classified into the roll technique, which we use in the modified Stillman, and we have the vibratory, which is used by the Stillman, Charters, or the Bass technique. We have the circular by the Fons technique. We have the vertical by the Leonard and horizontal by the Scrub. Patients with periodontal disease are most frequently taught a circular brushing technique using a vibratory motion, mainly to improve access into the gingival marginal area. You should keep in mind that the the plaque biofilm, it's mainly concentrated along the dentogingival area or the cervical area, which we call it as the target hygiene. So the method most often recommended is the Bass technique because it emphasizes the placement of bristles at this most important area. And the placement of the bristle and adapting the tip of the bristles to the gingival margin helps in removal of this plaque biofilm from this target hygiene. And the most common techniques, as you know, the roll technique for inflamed, and then if the modified Stillman for the recession. And the simplest and the oldest and the most common is the Bass technique. The Bass technique, it emphasizes the placement of bristles at the most important area. That is, I hope you know the Bass technique by now. We place the head of the bristles along the occlusal plane and the bristles at the gingival margin pointing at an angle of 45 degrees, and then exert gentle back and forth move from the last tooth, continuing anteriorly, followed by the palatal surface, then taking down to the area, and then continuing along the anterior palatal and the lingual surface, and finally ending up in the occlusal surface. Modified Stillman, the same, you can see the placement of the bristle. It's mainly used in patients with gingival recession because already there is abrasion of the margin. So the bristles are mainly placed away from placed above the gingival margin. Then we have the Charters technique. The bristle points are pointing away from the gingiva towards the proximal surface of the teeth. Brushing technique, always you start from the posterior teeth, advancing forward along the upper arch, followed by the palatal surface, going to the mandibular buccal area, followed by the lingual area, and finally ending up with the occlusal surface. Interdental cleaning. Now, any toothbrush, regardless of the brushing method used, does not completely remove the plaque. So, daily interdental plaque removal is crucial in augmenting or in helping the effect of toothbrushing, because most dental and periodontal disease originate in the interproximal areas. Now, the tissue destruction which is seen in the periodontal disease usually leave very big spaces like deformities in the tooth. As such, we have anatomical concavities in the tooth surface itself. The most common example is the mesial concavity you see in the maxillary premolar. And these are like the plaque retentive areas. So interproximal areas are not accessible to toothbrush and they retain the highest amount of plaque. And to remove these plaque, we have to use the interdental cleaning aids. And the most common one are the dental floss, wooden or plastic tip, or interdental brushes. So when we talk about the interdental when we talk about the interdental cleansing aid, dental floss is the most commonly used one. So what are dental floss? The dental floss, the use of dental floss, it's been widely used now. Dental floss are mainly of different types. We have the waxed and the unwaxed dental floss. The floss is made from nylon filaments, and then many studies have demonstrated no significant difference in the ability of various types of floss. So waxed dental floss, sometimes they leave like a waxy film on the proximal surfaces. So now we can use unwaxed, it's widely used nowadays. Now, various factors which influence the choice of dental floss include tightness of tooth contact, there is roughness of the proximal surface, and the manual dexterity of the patient. So, the recommendation of the type of floss should be based on the use of personal preferences by the patient. We have like the flossing technique, I hope you all be knowing it. Mainly, we make use of the floss, length is like 12 to 18 inches. We are wrapping it around the fingers and it should be like a tight together in a loop, and stretch the floss into the interproximal area, contact area, with a firm back and forth motion. Try not to snap the floss past the contact area because this may injure the interdental gingiva. Once the floss is apical to the contact area, wrap the floss around the proximal surface of one tooth and clean the area, and then move it along the opposite tooth, along the adjoining tooth, and clean the area. Move the floss across the interdental area and you can just repeat it like a back and forth. Make sure it is not in a sawing motion because it can injure the interproximal gingiva. Superfloss is available mainly to clean the pontic areas of the prosthesis, and also we can be used in orthodontic appliances. Many flossing devices are available in the market, and it can be helpful for the patients lacking manual dexterity and also for caregivers, which is assisting patients lacking manual dexterity. And the floss holder should be rigid enough to keep the floss taut and penetrating the tight contact areas. Even the disposable floss holding devices, it's available in the market nowadays. Toothpicks and wedges forms another thing. Toothpicks are very helpful in cleaning the interproximal areas. Now the placement of the toothpicks is very important. Toothpicks can either be with or without a handle, and toothpicks on handles that improve access to all areas and shown to be having an effective as dental floss in reducing the plaque biofilm. Even the wooden or the triangular shaped toothpicks are available. This design is more useful in the anterior areas along the buccal surface of the teeth. Rubber tips are also available, and rubber tips are sometimes available at the end of the toothbrush. They are reusable and can be adapted to any proximal surfaces. And it can even be used along the root surface for cleaning the interdental spaces. The rubber tip should be placed into the embrasious spaces so that we can effectively remove the dental plaque from the interdental areas. Coming to the interdental brushes. The interdental brushes are also very effective in biofilm removal, mainly from the interdental areas. As I told you before, in case of anatomical deformities, like in the mesial concavities, the floss completely does not remove the plaque. So the ideal thing is to remove the interdental brushes. So when we recommend the interdental brushes, we tell the patient to buy a diameter bigger than the interproximal spaces so that to clean the area properly. And also many studies have been done comparing the dental floss and interproximal brushes, and we found that the interproximal brushes removed great amount of interproximal plaque biofilm than the dental floss. And also it depends on the type of embrasious spaces. We can use like a single tufted brush, or we can hold it like a pen in a pen grasp and place the bristle over the tilted tooth and brush gently. When we talk about the interdental spaces, there are different types of embrasure, like with A, B, and C types. For the A type, it's a tight contact, we can use the floss. Whereas for the B, we can use the single tufted. And in C type, there is a wide space, we goes for the multi-tufted multi-tufted interdental brushes. Here you can see the difference in the anatomical concavity I was talking before. When you use a floss here, we cannot completely remove all the plaque. So in that case, we have to go for interdental brushes. Many oral irrigation devices are available nowadays. By oral irrigation devices, we mean like a pulsating stream of water into the subgingival areas. So we have used both supragingival and we have subgingival irrigators, which is available in the market nowadays. Now, along with these things, before we go to chemical plaque control, we usually tell the patient to do a gingival massage. Now, what is the advantage of doing gingival massage? Is that the massaging as such increases the epithelial thickening or increases the keratinization and the mitotic activity. And this keratinization, it helps to be more, makes the oral epithelium more strong or increased, make it into a more healthier state. Increased epithelial thickening and blood circulation are shown to be beneficial for restoring the gingival health. So as if there is no clinical evidence indicating that massaging of the gingiva is essential, but it is usually advisable to do so. Now coming to the chemical plaque control. Why we go for the chemical plaque control? Studies have shown that, the American Dental Association, the use of chemical plaque control has advantage and it holds a great promise in control and prevention of biofilm formation. And today, the American Dental Association has given acceptance for only two types of mouth rinses, which is mainly the chlorhexidine and the essential oil rinse. They can be used as a dilute solution, as a mouthwash, or as an irrigation. Chlorhexidine is the most positive antimicrobial agent which is used up to now. It has got an anti-plaque action, and it has got the property of substantivity, which helps in adhering to the oral tissues. And then the toxicity level is also much low. So it allows to be retained in the oral cavity for a long time. Now, many studies has been done on chlorhexidine, and then it's mainly recommended by almost 99% of dentists. Studies on chlorhexidine have shown that use of 10 milliliter of chlorhexidine twice daily in a concentration of 0.2% has greatly reduced the plaque biofilm in the oral cavity from 45 to 61 and gingivitis from 20 to 67. Also, another concentration is available of 0.12% in the market. Chlorhexidine, it has got advantage and disadvantage. The advantage is mainly the reduction in the plaque and calculus, in the gingivitis. The disadvantage is mainly there is like the staining. Transient impairment, the taste sensation. Now, the only thing we can talk about this is we have to tell the patient to discontinue the use of chlorhexidine after 2 to 3 weeks, and then after a period of time they can use again. Coming to the essential oil, the most common essential oil available in the market is like the Listerine or the Perio wash, and it's like also date back to very older days. Mainly, they also show plaque reduction of 20 to 35% and even gingivitis reduction. But it is less effective than chlorhexidine with minimal side effects like staining. So what are the recommendations? Why? What is the main recommendation in giving oral mouthwashes or the chemical plaque control? One thing you have to keep in mind is the cornerstone in periodontal therapy, it's the mechanical plaque removal toothbrushes. All the other things, including the interdental brushes, the irrigators, the chemical plaque control, cannot replace the mechanical plaque biofilm control. Patient motivation, it's the most important factor. How do you motivate the patient? We can use the disclosing agents. Disclosing agents, they are like wafers, which can stain the bacterial biofilm on the surface of the teeth, tongue, and gingiva. It's available in the tablet or even in the solution. You can ask the patient to chew the tablet and then spit it off, or you can apply with the cotton swab, and the dental plaque becomes visible. It becomes like an educational tool for the patient and also to encourage them to remove the plaque at home. And that is the main thing. It's like an educational tool. And then it requires patient commitment and regular visits. Maintenance phase is one of the most important things in the periodontal therapy. You have to keep calling the patient back, keep them in the loop, like talking about the maintenance phase, showing the improvement in his oral hygiene measures every time. And that is the main thing in periodontal therapy. So that's all about the plaque control. If you have any doubts, you can come and meet me. You have to read chapter 48 in the 30th edition of Carranza Kligman. It is very much in detail in the chapter. And still, if you have any doubt, you can always come and meet me or email me. Thank you so much.